I'm Kenneth Cutbush. I'm an orthopedic shoulder surgeon working in Brisbane. I'm here with Dr. Kigo Honaki from Osaka, Japan. He's an orthopedic surgeon working there. He's come to work with me as my shoulder fellow. And we're going to examine his shoulder because he's got a very interesting shoulder to examine. Kigo, can you lift your arms up to the side for me? Show us your range of motion. That's good. All the way back down for me. And then up to the front. And then back down, elbows in, thumbs up, twist out, and then up behind your back for me. And the other side, arm down. So you can note these little scars here. They're indicative of previous shoulder arthroscopy. Now, Kigo, we're just going to do the instability testing. So how's that for you? Is that okay?
Okay.
That's like that. You can see Kigo's already worried about what I'm doing, aren't you?
I'm already uncomfortable.
Yeah, that's uncomfortable. That's a positive apprehension test. If we went a little bit further, you'd actually see the muscles contract. What I'm doing there is putting the arm up into the apprehension test position. So this is for anterior instability. What it's doing is driving the humeral head forward and out the front. And as the shoulder feels that, he'll actually contract and try and stop me. The shoulder will stop me doing it. He'll actually ask me to stop doing it as well. So that is anterior instability. The next one I'm going to do is look for the what I call the inferior apprehension test. So I'm holding the scapula down because if I don't, the scapula will lift up. We want to isolate the glenohumeral joint. So I do that by holding on to the scapula and making sure it can't lift up. And what we're doing here is just seeing if this worries. Does that worry you?
No.
That's okay, is it?
That's okay.
So that's okay. So not so much inferior, it's more anterior. And then we come here, we're looking at posterior instability, turning the arm over to full pronation, and then asking here to push up towards the ceiling. And that doesn't worry you?
No.
So this is for posterior instability. What we're doing is pushing that humeral head posteriorly in the socket. And if there was posterior instability, typically what we get is discomfort, so pain in this situation, which is different to the apprehension. Now, the next thing I want to look at is with Kigo is his ligamentous laxity. So this is important to look at for any patient with shoulder instability or you think might have shoulder instability because it is an underlying issue that predisposes towards instability. Kigo, can you show everyone whether you can push your thumb down? So you can see, Kigo, I can't do that, and I'm reasonably flexible. I can't get there at all. Kigo, can you push your finger, middle finger back towards your, and I think if you push your wrist back, you'll actually show that you can get your finger almost parallel to the forearm. So that's pretty lax. What about your elbows? Do they hyperextend?
Yes.
So Kigo hyperextends the elbow as well. So there are other ones in the foot like ankle hypermobility, but this is very suggestive of ligamentous laxity. So his collagen is a little bit more lax than most of us. It's still within the normal range. What about shoulder hypermobility? How far can you externally rotate? So Kigo can rotate to 90 degrees of extension or external rotation, and then we're almost has shoulder hyperlaxity as well. What we're looking there is just how much I can abduct his arm, holding onto his scapula and keeping it down, and he's not quite there. So he's almost got shoulder hyperlaxity. So that is a great example of a patient with anterior shoulder instability.